All right, let's dive into the world of ECGs, specifically how to read them to figure out where a heart attack is happening. It's like you're a doctor, someone comes in with chest pain, heart attack symptoms, you get an ECG, and those squiggly lines can actually tell you which artery is blocked.
Yeah, it's incredible. Every second counts.
Yeah.
The faster you can open that blockage, the better.
So walk me through it. How can we use an ECG to pinpoint what's going on in the heart?
Well, think of the heart like a house,
Yeah.
right? And the coronary arteries are the plumbing, bringing blood to every room. You get your three main pipes, the left anterior descending, LAD, that's like your main water line. Then you got the circumflex and the right coronary artery, the RCA. If one of those gets clogged, the rooms it supplies start having problems.
So the LAD, that's like the living room, the kitchen, those busy areas.
Exactly. The LAD supplies the front, the side, and a lot of the wall separating the ventricles. Those are the main pumping chambers. The RCA, that's more like the basement, the back bedrooms, taking care of the bottom part of the left ventricle, the right ventricle, and even the SA node in those people.
Wait, the SA node gets its blood from the RCA. That tiny thing that keeps the heart beating in rhythm relies on that one artery.
It does, yeah. And that's why reading an ECG is so important. When an artery gets blocked, the heart's electrical activity changes. It creates what we call an injury vector. Imagine a spotlight shining from the damaged area.
Okay, I'm picturing it.
The ECG leads facing that spotlight. Those show ST elevation. You know, those tombstones we look for in a STEMI.
So it's like we're triangulating the source of a signal. By seeing which leads are picking up the strongest signal, the ST elevation, we can figure out where the blockage is.
Exactly. Let's go back to that patient with chest pain. Say their ECG shows a bunch of ST elevation in leads V1, V4.
Red flag.
Huge red flag. That's an anterior wall MI. It means the LAD, that main water line, is probably blocked.
So V1, V4, that's LAD territory. What if we see those tombstones in leads 2, 3, AVF?
That's pointing towards an inferior wall MI. Now it gets a bit tricky. You got to figure out if it's the RCA or the circumflex that's the problem.
Cardiac mystery time. How do we tell those two apart?
You got to look closely at the ST changes in leads 2, 3, AVF, I, and AVL.
Yeah.
Each lead gives us a different angle on that spotlight we were talking about. Let's pinpoint the source.
Like having multiple cameras on the heart, each one showing a different view.
Exactly. If the ST elevation is way higher in lead 3 than lead 2, it's probably an RCA blockage.
Okay, lead 3 versus lead 2. Got it. Anything else that helps?
Definitely. Look at the right precordial leads, V1, V3. With an RCA blockage, the ST depression there is usually much smaller than the ST elevation in the inferior leads. But if it's a circumflex, that ST depression on the right side is often bigger than the ST elevation below.
So smaller ST depression, RCA, bigger depression, circumflex, like a balancing act.
And don't forget lead AVR. It can be really helpful in spotting a circumflex issue. If it shows ST depression, that's a strong indicator that the circumflex is involved.
AVR always keeping us on our toes. But what about those times when the RCA is super dominant, like it's covering more territory than usual?
That's a good point. In those cases, the RCA might actually be supplying parts of the heart that the circumflex usually does. So you might even see ST elevation in leads V5 and V6, which usually point to the circumflex, even though it's actually the RCA that's blocked.
So the RCA is like wearing a disguise, trying to trick us. It really shows that you got to look at the whole ECG, not just individual leads.
Absolutely. It's all about putting the pieces together, like a puzzle.
This is so cool. All right, what about a right ventricular infarction? Those sound pretty scary.
They can be, yeah. The right ventricle pumps blood to the lungs. If it's not working well, things can go downhill fast. Luckily, they're not that common. They usually happen alongside an inferior wall MI when the RCA is blocked.
So how do we know if the right ventricle is involved? Is there a sign on the ECG?
You got to look at the right precordial leads, especially V3R and V4R. If they show ST elevation of 1 millimeter or more, that's a strong sign of a right ventricular infarction.
Got it. V3R and V4R. Anything else?
Sometimes you might see ST elevation in lead V1 that's higher than in V2. That's another possible sign. And a high degree AV block, that means the electrical signals are having trouble getting from the atria to the ventricles, is more common with a right ventricular MI.
Okay, high degree AV block, another thing to watch out for. Man, there's so much info packed into an ECG. What about posterior wall MIs? Those seem tricky.
They can be, yeah. Posterior wall MIs, or PWMIs, they often fly under the radar because they don't always have the classic ST elevations.
Wait, really? No ST elevation. What do we see then?
Instead of elevations, you often see ST depressions in the anterior leads, V1, V6. It's like the electrical activity is being pulled away from those leads because the damage is happening on the opposite side of the heart.
So the injury vector is pointing away, causing depression instead of elevation. That's kind of clever. And the more widespread the depression, the bigger the area affected.
Exactly. But figuring out if a PWMI is caused by the RCA or the circumflex, that can be tough. One clue is where you see the most prominent ST depression. If it's in leads V2 and V3, that suggests the circumflex is blocked.
Yeah.
Also, the posterior wall is almost always involved when the circumflex is blocked.
So if we see an inferior wall MI without ST depression in the anterior leads, that points to the RCA, since the circumflex almost always messes with the posterior wall.
Exactly. And if you're still not sure, leads V7, V9 can be helpful. They're placed on the back, closer to the posterior wall, and they might show ST elevation even if the standard 12-lead ECG doesn't.
Leads V7, V9, adding those to my mental toolbox. This is all so incredibly intricate. Before we move on, what about left main stem occlusion? That sounds serious.
It is very serious. The left main coronary artery is like the trunk of a tree. It branches into the LAD and the circumflex, so if that gets blocked, it's a big problem.
Yikes. So what does it look like on the ECG? Is there a giveaway sign?
The classic pattern is widespread ST depression in leads I and V4, V6, along with ST elevation in AVR. Remember, ADR often shows us what's happening on the opposite side of the heart, so ST elevation there can indicate big damage in the left ventricle.
Widespread ST depression plus ST elevation in AVR. That's the alarm bell for a possible left main occlusion.
Got it.
Got it. What if it's not completely blocked, but just really narrow?
That happens more often. It often presents as unstable angina. That's chest pain that comes and goes. The ECG can actually look a lot like triple vessel disease, where all three main arteries are significantly narrowed.
Wow, so even without a full blockage, a narrowed left main can mimic triple vessel disease. It really shows that you have to consider everything, not just jump to conclusions based on the ECG alone.
Absolutely. The ECG is just one piece of the puzzle. You have to consider the patient's symptoms, their history, other tests to get the full picture.
This is so complex but fascinating. It's like learning a secret code. Okay, one last thing. What about conduction disturbances? How do heart attacks affect the electrical signals in the heart?
Good question. Heart attacks can disrupt the normal flow of electrical signals. It can lead to things like bundle branch blocks. One common type is right bundle branch block, or RBBB, which affects the right ventricle.
Okay. And how does an RBBB show up on the ECG?
The most obvious sign is a wider QRS complex. That's the part of the ECG that shows ventricular depolarization. A new RBBB during an acute anterior wall MI often means the blockage is high up in the LAD, affecting a larger area.
So RBBB during an AWMI equals a proximal LAD blockage, another clue. And in general, any bundle branch block during a heart attack, that's not a good sign, right?
No, not usually. It usually means there's a higher risk of complications. Okay, ready to put those detective skills to the test? Let's do a little ECG challenge.
Hit me with it.
You're in the ER again.
Yep.
Patient chest pain. You got the ECG results. It shows ST elevation in leads 2, 3 in AVF, but ST depression in leads I and AVL. What's your first thought?
Okay, so 2, 3 AVF with ST elevation, that's got to be an inferior wall MI, right? But then the ST depression in I and AVL, that usually means, this is tricky.
It is tricky, but remember what we talked about, those differentiating factors. Think about the leads, how much ST elevation versus depression there is. Any other hints the ECG might be giving you?
Okay, let me think. We got that inferior wall MI pattern, but the ST depression in I and AVL is throwing me off. It's almost like, wait a minute, could this be one of those RCA dominance situations?
You're on the right track. Dominance can definitely mess with those typical patterns.
If the RCA is dominant, it could be supplying more of the inferior wall, even dipping into territory that the circumflex usually covers. So even though we see that ST depression in I and AVL, which usually points to the circumflex, it could actually be the RCA causing the problem because it's running the show.
You're getting it. What other clues on the ECG would support that idea?
Well, if the RCA is the troublemaker, we might see ST depression in those right precordial leads too, V1, V3, right? And that depression would probably be less than the ST elevation in the inferior leads.
You're putting it all together. Each lead is like a clue, and you got to look at the whole picture to solve the case.
Feeling like a cardiac Sherlock Holmes over here. But seriously, it shows you can't just jump to conclusions based on one lead or a simple pattern. You got to consider all the possibilities.
Couldn't agree more. The ECG is powerful, but it's not perfect. You always got to combine what you see on there with the patient's symptoms, their history, other tests. Got to get the whole picture.
So we talked about specific patterns, but are there any rules of thumb or algorithms doctors use to get even more precise?
Absolutely. There are actually several algorithms out there designed to help doctors interpret these findings. It's like having a cheat sheet for heart attacks.
That sounds pretty useful. What's an example?
There's one called the three-variable model. It helps differentiate between LAD and RCA occlusion in inferior STEMI.
Three-variable model. What are the three variables?
It looks at ST elevation in lead 3, ST depression in lead V2, and the heart rate.
Okay, so how do those help us figure out which artery is blocked?
The model gives you points based on each feature. Like if the ST elevation in lead 3 is 1.5 millimeters or more, you get 3 points. ST depression in V2 of 1 millimeter or more, that's 2 points. Heart rate less than 70, that's another point.
So we add up the points. Then what?
If the total's 5 or 6, it's highly suggestive of an RCA blockage. Scores of 3 or 4, more likely LAD. But 0, 1, or 2, it means either diagnosis is less likely. Got to investigate further.
That's pretty straightforward. Are there other algorithms like that?
Tons. Each one has its own criteria and calculations. Some are specific for certain types of MI, like the King's score for proximal LAD occlusion. Others are more general, like the STEMI decision aid that helps decide if a patient needs immediate intervention.
So it's like having a whole toolbox of algorithms to get the most accurate diagnosis.
Exactly. And as we learn more, these algorithms keep getting better and better.
It really is a whole science. It's not just about finding those tombstones.
It's a puzzle, a mystery to solve. But instead of finding treasure, we're potentially saving a life. That's what makes it so rewarding.
I like that. Okay, hit me with another challenge.
All right, let's switch things up. You're a cardiologist reviewing an ECG, patient with suspected STEMI. The ECG shows ST elevation in V1, V4.
Okay, so that's anterior wall MI, right?
Right, but there's also ST depression in 2, 3, and AVF.
So classic AWMI with some added ST depression in the inferior leads. Didn't we talk about something like this? Reciprocal changes or...
Good memory. Those are ST depressions that show up opposite the main injury vector, like the ECG is trying to balance itself out.
Right, so maybe that ST depression is just reflecting the ST elevation, nothing to worry about, just the ECG doing its thing.
It's possible.
Yeah.
But remember, good doctors always consider other possibilities. Could something else be causing those ST depressions?
You're right. Can't just assume it's reciprocal. What else could it be?
Think about the different types of MI. Could there be another area involved, one that's not obvious from those initial ST elevations?
Hold on, I think I got it. Could those depressions actually be a sign of a posterior wall MI?
Bingo. You're a natural. Remember, posterior wall MIs often show up as ST depressions in the anterior leads. And because the posterior and inferior walls are so close, it's not uncommon to see them both affected.
So we might have two MIs happening at once, anterior and posterior. That's intense.
It is, and it really highlights why we need to look beyond the most obvious pattern. There could be something hidden, something less obvious going on.
This case really shows that ECG interpretation is more than just memorizing patterns. It's about understanding what's happening and picking up on those subtle clues.
Exactly. It's about developing that intuition, that sixth sense for what the heart is trying to tell us.
I'm learning so much. Okay, I think I'm ready to put it all together and tackle that final challenge you mentioned earlier. Let's do it.
Right, before we get to that, let's recap what we've learned so far. What are some of the key things you've picked up about ECG localization in STEMI?
Well, first off, time is critical. The faster we can identify the blocked artery and open it up, the better for the patient.
Absolutely. And that's where ECG localization comes in. By looking at those ST segment shifts, we can pinpoint the problem area and guide treatment.
We learned that each coronary artery has its own territory, like a map of the heart. And when an artery is blocked, it creates a unique pattern on the ECG.
We've explored those patterns, from the classic anterior wall MI with the LAD to the more tricky patterns with inferior wall MIs, which can involve either the RCA or the circumflex.
We even covered those less common MIs, like right ventricular and posterior wall MIs, showing how important it is to look beyond the standard 12 leads and consider those extra leads.
And we learned that dominance can throw a curveball, making those patterns harder to read. But with careful analysis and an understanding of the anatomy, we can usually figure it out.
And those algorithms, those are helpful tools to get a more precise diagnosis.
Great summary. You're thinking like a true ECG detective. Now, are you ready for that final challenge?
Bring it on. Feeling confident and ready to put my knowledge to the test.
Perfect. Imagine you're back in that cardiologist role, reviewing an ECG for a patient with suspected STEMI. This time, the ECG shows.
Okay, so the ECG shows ST elevation in leads V1, V4, but there's also ST depression in leads 2, 3, and AVF.
So it's that classic anterior MI pattern, but with ST depression in the inferior leads. Are we seeing those reciprocal changes again?
It's definitely possible. Remember, those ST depressions can show up opposite the main injury vector? It's like the ECG trying to find balance.
Right, right. So maybe
Oh,
it's just the ECG balancing itself out, nothing to worry about.
that could be it. But remember, we got to consider other possibilities. Could there be something else causing those ST depressions?
You're right. Can't just assume. What else could it be?
Think back to those different types of MI. Could there be another area of the heart that's affected, one that's not obvious from the ST elevations?
Wait a minute. Could those ST depressions actually be a sign of a posterior wall MI? Exactly. Posterior wall MIs often present as ST depressions in the anterior leads, not the typical elevations. And remember, the posterior wall and the inferior wall are super close together. It's not uncommon to see both affected at the same time.
So it could be both, an anterior MI and a posterior MI happening at the same time. That's a lot to deal with.
It is. And this case really shows why we can't just memorize patterns. We have to understand the physiology and look for those subtle clues that might point to a more complex situation.
This whole deep dive has been amazing. I'm starting to see just how complex ECGs really are.
It's more than just looking for those tombstone ST elevations. It's like learning a whole new language, deciphering the heart's electrical whispers.
All right, bring on that final challenge. I'm ready.
Okay, last one. You're evaluating a patient with sudden, severe tearing chest pain that radiates to the back. Their blood pressure is different between their arms, and you hear a new murmur. What's your top diagnosis?
Whoa, this is different. Those symptoms, that sounds way more serious than just a heart attack. Tearing chest pain, radiating to the back, blood pressure differences. That's got to be aortic dissection, right?
You got it. Aortic dissection is a life-threatening condition. The inner layer of the aorta, that's the big blood vessel coming out of the heart, tears, and blood surges through, creating a false lumen. That can block blood flow to vital organs. It can even rupture, which is often fatal.
That sounds terrifying. Is the ECG helpful in diagnosing that?
The ECG isn't the main tool for diagnosing aortic dissection, but it can give us some hints. Sometimes you see signs of ischemia, kind of like a heart attack, because the dissection can block blood flow to the coronary arteries. But the most important thing is to be suspicious based on the patient's symptoms. Time is critical, even more so than with a heart attack.
So in this case, we wouldn't spend time analyzing those ST elevations and depressions. We'd focus on stabilizing the patient and getting them imaging stat.
Absolutely. Aortic dissection is a surgical emergency.
This case really shows how important it is to think broadly and not get tunnel vision when someone comes in with chest pain. There are so many possibilities besides a heart attack.
Exactly. As clinicians, we have to keep an open mind, consider everything, and never stop learning.
This has been a fantastic learning experience. I feel a lot more prepared to approach ECGs and chest pain patients with confidence now.
It's been great sharing this with you. Remember, learning never stops, especially in cardiology.
Thanks for the inspiration. And to everyone listening, thanks for joining us on this deep dive into ECG localization. We hope you learned something new and feel empowered to keep learning about this fascinating and vital part of cardiac care. Until next time, stay curious and stay heart healthy.